Hi, everybody. My name is Sue Bowles. I am the nurse consultant for the FPQC Paired Initiative. I'd like to welcome you all to our webinar today, Creating, Sustaining, and Growing Patient Family Councils in the NICU. And our presenter today is Lelis Vernon, and she is an NICU mom and our own state family leader here in FPQC. Lelis collaborates with different healthcare entities nationally and internationally. She is an advocate for family engagement and promoting family-centered care. And Lelis holds a Safety, Quality, Informatics, and Leadership certificate from the Harvard School of Medicine. So Lelis, with that, I'm going to turn it over to you.
Great. Well, good afternoon to everybody. It's great to be here. And today I'm going to do two things. I'm going to share with you my lived experience as a NICU mom, and I'm also going to show you a compilation of guidelines and resources and evidence and tools that are available for you regarding the creation, sustaining, and growing patient advisory councils. So yes, I did that for you. I went through all the recent publications, and what I did is condensed the main points that are going to guide you as to what to do if you're interested in having a family advisory council in your unit. And then I've sprinkled throughout the presentation my lived experience in the NICU. So as a way of introduction, I am a NICU mom, and we are a NICU family because we, the five of us, stayed in the NICU for 4 months. And these are my two whys. I do what I do. This is Charlie up top and Bobby in the bottom. They're micropreemie twins. They were born at 1 pound, 25 weeks, and we stayed 4 months in the NICU. And throughout our stay, I really felt there were some gaps in care, and mostly they had to do with peer support and family inclusion and family engagement. And that's why after graduating, I went back to the NICU where the twins were born. And together, as you can see up top, we were inaugurating here the family lounge of our NICU. We cut the ribbon together. We also went every Christmas and we made donations for the families. And all throughout the 4 or 5 years that I was volunteering at the NICU, we had over 200 families registered in our Patient and Family Advisory Council. We had 5 families cleared in the volunteer services and sitting in quality improvement teams. We had also a newsletter that I'm giving you here a screenshot. It was a lot of work, but it was very well received by everybody. But after 5 years, I discovered that I had really a passion for data and outcomes for babies. So I did what I call jump the isolate. So I went to the clinical side and started collaborating in quality improvement and research. But nonetheless, I'm going to show you today what is all about having a family advisory council. So let's start by defining what are family advisory councils. And they're organizations of current or former patients, family members, and caregivers that work together to advance best practices at the hospital or healthcare organization. And I like this definition because of a couple of points, 3 points really. It says former patients, and I know it's kind of funny to think that of NICU babies being in the advisory council, right? But I can tell you this is a new generation of NICU graduates that are indeed going back to the NICU and mentoring families. Locally, as you might remember, we have an association with ICU Baby. They service the 5 largest NICUs in South Florida, and my twins, my graduate twins, are ambassadors, and they do indeed go back to the NICU and talk to families. So I think it's important to bear that in mind. It's not just really transcending the families, it's incorporating patients. And then caregivers, we have amplified the concept of families, and you will notice I do not use parent because caregivers are really all the loved ones that are giving care to our NICU babies. And that includes the LGBTQ families, surrogates, adoptive families, And most important, during the COVID times, we saw a big surge of grandparents coming to be the caregivers of the baby, since they were the first ones to receive the vaccinations. So I think those are very important points to bear in mind. And lastly, it says not just at a hospital, but also at a healthcare organization. And so it's very important to bear in mind one big word of the day, which is variation. When it comes to family advisory councils, you will see that these organizations vary not only in the number of people that serve in it, but the nature of their function and their level of engagement, and also what level of engagement, at what level within the healthcare organization they do the engagement. Sometimes it's at a unit level, like in the NICU, and sometimes some hospitals have the capacity to have hospital-wide committees with representation from all their different hospitals and different departments. So lots of variation. Bear that word in mind for the rest of the presentation. So for the most part, when you look at the functions of family advisory councils, you will see three main domains. One is about advising. It's when the council members have a passive role and they just advise on projects, policies, or initiatives that the hospital staff initiates. Then you have implementation. It is when, yet again, the hospital staff has a project and they need to translate whatever they're trying to implement. And the translators are really the families for the implementation. This is a passive, active role, dual role of the council. Then you have a hybrid where the council members advise on projects, are co-designers in policies and change initiatives, and then also are part of the implementation of this project. So it's really co-designing and implementation all throughout the continuum of quality improvement or research projects in your unit. And lastly, I added this one. It's sustaining family-centered care in the unit. And that is going to be done by having a scalable and sustainable group that is going to provide the family voices to the council. I'm going to show you how to do this in the how-tos. So the values of the family advisory councils are, for the most part, is to promote patient and family-centered care pillars, which are collaboration, information sharing, dignity and respect, and representation. Then the families also are the essential allies for quality improvement and patient safety. This is not just semantics. This is actually science. The science of quality improvement and patient safety show us that the voice of the consumer is not just advisable, but a requirement as maintenance of both pillars in healthcare. For qualitative real-time feedback, we're going to talk more about that, but I can tell you that at PQC levels, this is being widely used, getting feedback from families at the bedside, provision of perspectives that are different from those of staff. Some family advisory councils are made up of staff and families, and sometimes the percentage and the weight of one group or the other also vary. However, it is highly recommendable that you not only have families, but a lot of diverse families. And we don't mean that in the racial, ethnic perspective only, but also in the outcomes and the length of experiences of these families. Because really, it is only by the lived experience on the other side of the isolate that you can really grasp the richness of each family story. And each family story does bring very valuable data points for you to consider in your projects. You also have incorporation of the family experience into all aspects of healthcare operations. And I like this one because it's not just about having the families redesign nice signs around the NICU, but it's really elevating their voices, perhaps up to the leadership department I, at some point, sat in the corporate division of the hospital where my twins were. And really, when you level the voices of families up and down the spectrum, it is very interesting to see how the conversation at the table really changes. Creation of the venue for Walk the Walk and keep keep the units within their mission and vision. I would refer to this point as an accountability of what NICUs are all about. You might read the mission, you might see the vision, but really when you walk around the NICU and you see the families mentoring other families and engaging with the staff is when you see, okay, this is really happening. Aiding in the development of effective patient safety and quality initiatives, and the creation of efficiencies in which the Family Advisory Council can have input, identifying the right fit for policies. And this has to do with projects that have to do with the needs and wants of the consumer, of the families in the unit, and not just for the business part of the NICU or for the requirements of X, Y, and Z when it comes to the clinical processes of the NICU. And I really like, this is my go-to photograph, you don't really want to have a NICU where all the dogs are going to be sitting down taking care of the cats. You do want the cats also to have a say in their feline healthcare. So some other characteristics of PFACs, and again, these are all umbrella terms and umbrella definitions that you have to take and really model to the needs of your unit and to the needs of the population that you serve. But basically you have two big hubs. One is the hospital-wide committees, as we mentioned before, or unit-based. Again, a lot of variation, as I mentioned before. The authority of these groups also is very, very variable. You have families that are used, family advisory councils that are used only for voting rights, and others that are partnering with staff for creating the voting process or creating the projects and seeing them through. When it comes to membership, this has to do a little more with the hospital-wide initiatives. And again, you can have families of current patients for feedback at the bedside. You have these families that are called the frequent flyers that have a lot of experience to be in and out of the hospital with very valuable experiences. As advisors only, as we said, with a passive contribution to your advisory council. And then finally, advisors and staff as members of the same team. And then training, we're going to talk about a little more about training, and I did include a number of tools in the toolkit that I'm going to share with you at the end. But this has to do with hospital orientation, the orientation meeting that the Family Advisory Council might have at one time or monthly until they reach maturity to serve in the unit, or a tiered advisory and leadership training. So the challenges, I just put here some of the challenges. The challenges are many, and you will encounter your own when you are implementing and creating your own Family Advisory Council, because each unit is unique, just like each NICU baby is unique. So I would put at the top of the list budgeting and really creating a niche for the family leader of this Family Advisory Council. And the niche to me has to do with a physical space for the family. And a physical space, I don't mean only in terms of a little office or a little place where to put the material that the families are going to be using in and out for their PFAC, but also a physical place at the table, in the decision-making tables. And that can be super, super tricky. Aligning family and administration expectations regarding function, scope, and authority. Again, we're going to talk more about the role of leadership and elevating the needs of families as advisors in the unit. this can be a misalignment, and unfortunately when there is a misalignment, then one person is pulling one way and the other person is pulling the other. It doesn't serve anybody. Sustaining family and provider interest in the work, it really comes from a framework of how much do you value the voice of the family, right? Is it important for you? Was it important just to receive advice at the beginning of a specific project? And that is that. You're going to sit the family at the side and continue doing the work with the rest of the staff and clinical team? Or do you want to sustain that voice throughout the life of your NICU? Balancing staff and family input. This, again, it has to do with how much you value the voice of families. I've been in teams where the Family Advisory Council was consulted at the time of drawing a global aim of a project, and that was it. And I think it's important to point out here that clinicians, for the most part, have been educated to put conditions at the center, right? So this is really a different dynamic. So this is not to blame anybody. I think it's just learning a new culture of care delivery where you have the family at your side. Assuring equal voice among family participants. Something that we learned during the pandemic is that those families that can't reach the unit can be easily reached by technology, Zoom, FaceTime, texting, email. So I would say that you make sure that the family that is sitting at the table with you or that is representing the Family Advisory Council really amplifies the testimonies and the stories of other families, that is able to bring the story of other families to you. Assuring the Family Advisory Council engagement is meaningful work, accommodating the slow process of change, because I'll tell you, as a family, I went to the unit and I said, oh, you know, we have to do this and this, and we are full of ideas, and everything to us looks very easy because it's kind of, it kind of makes sense for us. However, the politics and the rhythm of quality improvement and processes of change is quite slow. And that is something that we have to respect and learn to respect. And finally, marketing the Family Advisory Council within the unit. We'll talk a little more here in the how-tos. So when you're trying to put together a Family Advisory Council, the first thing you're gonna have to do is pause. To get ready, you have to take the temperature of the unit. And that means, you have to really survey, are you guys all on the same page with the need of onboarding families to have a Family Advisory Council? Do you have a family-centered care culture in your unit? Are you all cognizant of the fact that, you know, a rich NICU is one that incorporates the lived experiences of families? So once you have made all of this survey of the staff, then you can start toying with the idea of bringing families to the table. And so to me, there are two very important parts. The clinical part is going to be, first, inform leadership of the need of having a patient on Family Advisory Council. You will have to bring the evidence and you will have to show them the numbers, because that's the way it works. But I promise you, if you don't have leadership buy-in, you will fail. Unfortunately, that is the way it goes. Informing the unit of the PFAC formation. I can tell you, I was there 5 years and it didn't fail. I would show up at night and I would talk, hey, we are implementing this new tool at the bedside. Did you see any? Who are you? What are you doing here? What is the PFAC? I didn't know. So it's very important that everybody is on the same page, so that the families that are volunteering or bringing back their experience are feeling welcomed. Designate a staff liaison. This person is going to have a lot of patience. It's going to be a very special person because this person is going to be in charge of communicating with the family or really doing a lot of hand-holding. And it's going to be in charge of the next 3 points. One is securing a venue. You need to have a room, a designated room. And if you do not have a designated room, and if you have to make reservations for the Family Advisory Council to meet, then you will have to do this beforehand, because there is no greater challenge than having 5 families at the door and no room to get together. There needs to be a secondary liaison, somebody that is not only up to speed with everything going on with the Family Advisory Council, but needs to, but is available to help the family advisor when they are in the unit and the main liaison is not around. And it's also somebody that gives you a hand with printouts, with budgets, with communicating with families at the bedside, with clearing access at some point. So we need liaison number 1 and number 2. And finally, you need to line out the media and tech tools. So what format is this family advisory going to have? Are you going to have conference calling, Zooming, FaceTiming? Are you going to have a social media presence? How often are you going to meet? And what are the general goals? This is the framework that you need to establish before onboarding the families. And then when it comes to the family needs to first, you need to identify it, but then you need to welcome them. The families need to have a very clear idea of what they're going to be doing around the unit. Then the family has to go through the volunteer department. In the volunteer clear in hospitals varies a lot. It can be a 2-week training, or it can be a 3-month training, as the one I did. And they took me everywhere, to lab and cardiac, and I didn't know what I was doing there, but it was part of the process. So it's very important to have the families clear with the volunteer department. And then once they do that, they can receive education and training about all the things that they can do and all the things that they cannot do in the unit, in the NICU, and then all the things that they can do or they should be doing as family partners, as in their role as family partners. And then finally, hold an onboarding meeting. And with that, I mean, after doing all of this, you still have to ask the family, are they able to perform at this level? Are they ready to perform at this level? And then get all the feedback that you can from them. Remember, this family is leaving behind a NICU graduate, and in my case, 2 NICU graduates to go partner with you and work with you in the unit. And finally, please make sure that this family and anybody else in the Family Advisory Council meets with the leadership of your unit and meets all the staff. So I get this question a lot, but where do we find the families? So here I'm going to show you Edward Demings and Joseph Uram, 2 gurus of quality improvement, devised 2 distinct ways of getting the voice of the consumer. One is an active way on your left-hand side and a reactive way on the right-hand side. So the first one has to do with advertising your project. This could be in ways of brochures and QR codes, as we have piloted already here in the Skin to Skin project. This could be in ways of interviews, perhaps evidence-based co-design. I'm not sure how many units are aware of this new modality, but it's being implemented in a lot of units working in quality improvement right now in the US. And this is a little resource heavy. You need to have a camera, light, a room, staff, editing powers, and of course you need to invite the families. But this could be also done easily at the bedside, just having an informal conversation with families and seeing where they're at and if they are interested in collaborating with you. Focus groups, it can be other groups that are existing in your hospital system, or I would strongly recommend you go to community groups. This is a new thing that has emerged after the pandemic. Feedback, as I mentioned before, is the feedback, the fresh qualitative assessment of how care is being delivered live These are all the families that are at the bedside, and you can just tap them on the shoulder and tell them, hey, we have this idea or this project. Would you like to be part of it? Customer-facing employees are all of you, all the nurses, all the doctors, all the specialists that have had interaction with families and that know, who are the families that are at the bedside, who are the families that are making interesting questions, and perhaps there are also the families that are not in the unit. Those are the families that can come to the unit, but nonetheless, they call and they make informed questions to you. Who do you see is growing in their advocacy for their own babies? Those might be good candidates for your family advisory council. And finally, NICU reunions. That was the best event. We had a table with other families, and we just recruited everybody that came to the NICU reunion. So if you have the ability to have one, please have a table. You're going to fish a lot of families there. And then on the reactive side, you have the surveys. A lot of families might tell you in their surveys, Presgani or whatever you are implementing, that they would like to serve, that they would like to collaborate. Follow-up phone calls. I find these to be very fruitful because the families feel very comfortable once they're home, and that once that they are that they don't have this retaliatory fear that NICU families have when they are in the unit. So once they are safe at home and you call them for follow-up, they might express their interest. And if not, this is a good way of asking them if they're interested in coming back to the unit. And then finally, reviews. We need to pay a lot of attention to social media. In our last family reunion here in South Florida, I discovered 3 new community groups that were born in Instagram, and they have a lot of followers of families, local families. And so it's an easy way of putting hashtags in Instagram and other social media to discover where the families are at. So who are the family partners? These are families, of course, that have had a NICU experience. That's a must. But it is also important to know if the family has coped well with their NICU experience. These are families that need to elaborate their NICU experience and put it behind, because they can't bring that to the family advisory council. It would not be productive for the family or for the team. They need to be able to leave their NICU grad to attend meetings. They need to be willing to talk about their experience effectively and share insights and information. Demonstrate a passion for quality improvement, of course. Have the ability to listen, respect the perspective of others, and interact with many different kinds of people. This goes also for the staff that is partnering with families. Enjoy working with others, show a positive outlook in life, and a little sense of humor. Some families need some space to relate perhaps their negative experiences, and so there needs to be a space for that. But when it comes to family advisories, it is important to have an upbeat and a positive attitude by everybody. And finally, represent a broad cross-section of the hospital population. Again, diversity is also the name of the game. This is our family team here in the Florida PQC. I'm so proud of this, and we were able to really bring, and I think it's the most diverse group I've ever worked with, and we are very proud. I think our projects are all the richer for having all these families. So the data. I want to show you some numbers because we have some fresh numbers. The 55% of families serving as family partners are volunteers, but this is a big shift from pre-pandemic times, and I'm very happy to say that I see a lot of families starting to get paid. And 75% of them have experience in their roles for 5 or more years. So this is very, very interesting. Now, there are a lot of variations. There are a lot of variations in the length of stay of these families in the NICU, of the outcomes that they had, and also on the time lapse after discharge. Some families come right away. Some families have to wait 6 months. Some families have to wait 1 or 2 years. It depends on the unit, so lots of variations there. But when it comes to sustainability and scalability, I see three big phenomena. One is engagement of community groups. This was a big surge during the pandemic, and I think it's continuing to have traction. A lot of units are resorting to community groups to gather the voice of the consumer, and then also implementing the virtual expansion of their family advisories via Zoom. And then I see a little back to the future effect post-COVID as well, where a lot of units are comfortable saying, oh, we're welcoming the families back at the bedside, but yet the real family center care spirit is gone. So we need to work at re-implementing the spirit of family centeredness in the unit. It's not enough to have the family at the bedside. It really needs to be a full engagement of the family in all aspects of care delivery. So a little bit of the temperature of what's going on with PFACs in the nation nowadays. The map on the right here is a fresh publication from February of this year. And it's how we're doing as a nation when it comes to advisory councils. And we're doing okay. I am quite surprised actually at some of the states. I know that Texas has 3 of the most important nationwide serving community groups that are serving families nationwide. So I don't know why that color, but it's quite good. And then on the left, I included this PCORI tool also that was recently published in 2021. But I do have to say, you will see a lot of the evidence that I put in the toolkit with a linear progression of the roles of families in advisory councils. I don't think this is necessarily the truth, and I'll tell you why. I did a survey with the Vermont Oxford Network units, and some families start at the stakeholder level, right? And some families start at just informing, being just passive advisors, and they stay there. So I think that there is a lot of variation, but there are families that serve and do everything in between. So I invited Mary Abraham from the Institute of Patient and Family Center Care to redesign this tool. So we're meeting this week. Maybe in the near future, I'm going to show you a new tool. Compensation. We have to talk about compensation because everybody at the table, clinical staff that is working on this, is being compensated for their time. And this is a poll, a survey that came out 2019 from the Patient and Family Advisory Network. And you can see here the values. I think these are pretty standard nationwide. And also when it comes to compensation preferences, I've seen a lot of NICUs giving families gift cards, either for specific stores or stipends for gas. And of course, the covered parking as well. And I think this is very important. Volunteering in perpetuity translates into unsustainable family advisory councils. This is a survey from the Institute. They recently published it, and I like it because it has fresh data for post-COVID. So it looks pretty good. However, the PFAC for the Institute is a representation of all family advisories, not just in NICU. So this is representation of adult population as well. But it's good. It's actually great that only 8% of hospitals is in the developing stage of family advisory councils. And then you can see that most hospitals have more than one family advisory council. And then in the history, this was very interesting that the PFACs that have been in existence, more than the majority has been around for more than 10 years. That is fabulous. And out of here, the adaptations for the post-COVID, post-pandemic times, this was very interesting. the family advisory's involvement in COVID committees was rather small, but you will see a shift in the modality of how these PFACs are getting together. So that is data, and now here's the toolkit with a lot of the evidence that I collected, a lot of the guidance and the data. You can scan this. It's a Google Drive with a lot of material, and I'm sure you have a lot of questions, but I would recommend that you bear in mind that these are general rules, but ultimately the formation and the sustaining and growth of your family advisory council will be tailored to the needs of your unit. So with that, thank you very much. So we have some time for Q&As.
Does anybody have any questions? Or if you're shy, you can put it in the chat and we can read them. No questions?
I have a question.
Go ahead.
What's the maximum time frame from like discharge to, like, what time frame would you put on, who are the best caregivers to put into your PFAC? How long from discharge to like still contributing? I don't know how to phrase the question.
Sure. So the variation is huge. So my personal experience was having a father of twins that had been discharged 2 months prior to him showing up in one of our meetings. And I said, oh, you know, I'm not sure about the clearance because of HIPAA and this and that. And so I said, I would recommend you stay home. He said, no, you don't understand. I'm trying to escape the twins. So please take me. So this dad was only 2 months after discharge. And then we have units that impose a 2-year wait for families to get back. So, you know, it varies. I really don't know why such a long time. I think it was HIPAA related. But I think that we are demystifying HIPAA as time goes by, especially now post-pandemic when we saw Zooming, you know, with cameras or rounding with cameras at the bedside, and everybody was was on camera. And then in terms of, let me flip then your comment a little bit. Then in terms of how much these families are serving, I do see still, you know, in the early 2000s, we had this policy, and I don't know why it was so popular, but families were welcome to serve for 2 years, and that was it. And my recommendation is not only that they stay more than 2 years. I think that the learning curve for families is a minimum of 2 years, because you have to realize that after being discharged from the NICU, we need to take care of our NICU grad or NICU grads. We need to elaborate the story, right? We need to get over the story, and then we need to pluck up the courage to go back to the NICU, and then we need to be educated, and we need to be trained, and then we need to be also trained about family-centered care and the politics of the unit. And then it's when you are really, really useful as a family partner. So the learning curve is really lengthy for us. So most modern units are doing away with that rule. So I can tell you that in Vaughan, for example, the 7 family leaders, we have had more than 10 years in advisory council experience, and are now serving as leaders. So that's an important point to bear in mind. Let's see, we have a couple of questions. What do you see is the biggest barrier to sustaining once it is started? Compensation, number one. And you have to start by leadership, but I will assume that you have leadership if you have already a PFAC, but compensation, I think it's the biggest hurdle. And then structuring, where do you put this, right? The Institute of Patient and Family Centered Care just did an informal survey, and a lot of the PFACs were reporting that they are, for the most part, under the quality and safety department. A lot of units don't know where to put these PFACs. If you don't have a PFAC, what is the small test of change to get started? I would say we have an ad hoc team here in the FPQC. So I would say that the biggest challenge starts with the staff, right? Because the staff needs to be comfortable having the family in the unit. So as a little test of change for the staff, I would say, hey, we have this project, whatever project you have going on, why don't we talk to a handful of families and let's get this dynamic, going. Let's get the staff trained to interact with the families. I know that staff interacts with the families every day, but when you're collaborating and when you're having the families come back, it's different. The dynamic shifts. It really is different. The dialogue changes, the conversation changes. So I would say if you can put a handful of families to do an ad hoc, and then get the staff to ask them a couple of questions, and then see how the staff manages that feedback from families. That would be the smallest test of change. And then, Bill, we also did a small project in one of the units that did not have a PFAC, and we invited families to change the signage around the unit. And so that had a huge impact because everybody welcomed new signs and not only the staff, but the families welcomed the signage. It was an easy thing to do. So yeah, 2 small examples.
Are there any other questions that anyone has? No other questions? Well, if we don't have any other questions, Lelis, thank you so much. This was so informative. It was such a wonderful webinar. We really appreciate it. And, let's go get those patient and family centered committees up and running in our units if you don't have one, or let's strengthen them if you do. Bill, you have something?
Oh, I just wanted to thank Lelis for an outstanding presentation. And I think the message she's saying is just get started. Just begin. You got to take one step at a time, but every step will do better with families.
Mm-hmm. Yes, of course. You're getting a copy of the slides, and you're also getting the toolkit. So I'll make sure that the toolkit, the Google Drive that I put together is sent to you guys, so you can read. There's a lot of stuff to read.
And the webinar is being recorded so that they have the opportunity, because I know some people maybe want to share it with their staff, and your staff maybe couldn't hear it. So it will be up and available as a recording so that you can share. And Bill, you have your hand up?
I was clapping.
Oh, sorry. I'm so used to seeing your hand up. I just go right to that.
Hi, I have a quick question, Lelis, if you don't mind.
Sure.
As far as we had a family council before COVID, pre-COVID, it's always been a very small group that we had, and they weren't really current NICU families. They were more from like way back.
Mm-hmm.
So that's one of my goals for this year, is trying to reestablish that. So would you recommend reaching out to those parents that were in it and the ones that were leading it to, I don't want to hurt anybody's feelings, sort of thing. And because we stopped it because of COVID. So to bring it back and say, okay, well, you were the president, but you're not now. Do you see where I'm going with that? That I want to give everyone a fair chance, but yet I don't really even know. We had a hard time even getting people on board to do it. It was always that small group, but So it's just the dynamics of trying to get together, who to ask, and if I should reach out to those old people. Of course, we want them in there, but
Yeah, absolutely. You have to. You have to. The families that were already carving time off their busy lives and family lives to collaborate with you and to grow in partnership with you. Of course, you have to reach back to them. It would be really damaging if you didn't.
but
So
as far as the positions, more so is what I'm referring to. That, you know, do we pick up where we left off? Like the president was the president and the,
yeah, absolutely.
just
And
leave it as that if they're willing. And go
Yeah.
from there. That's
Yeah,
more was more my
absolutely.
question.
Yeah, and they also know what they were doing, right? So they were also in the dancing, you know. So they know the dynamics, and that's very. So if you are trying to graduate these families and you want new and modern voices post-pandemic, then I would put a nice challenge to those families and say, hey, you're back, but we need you to train. We need you to mentor this new generation of families. Just to diversify, just to amplify the voices, nothing like because you're going to be replaced, right? But I'll tell you, the voices post-pandemic are very different from the voices pre-pandemic. They are very different. And so they're both very valuable, of course. And I also think that if you did a longitudinal study of the challenges that families have, I promise you that post and pre-pandemic, they still exist: communication, information sharing, dignity and respect, and everything else. But yeah, I would invite them back. I would just challenge them to to think through a restructuring of how they are going to continue partnering with you. Where do they see the council going in the next year, and in the next 2 years, and in the next 5 years? Propose a growth plan. The one thing that we are lacking in family advisory councils is the framework, right? We'll just bring the families to the unit, but then what, right? So I think that point of growing it, that challenge for growing it and put it in on the families is great. Is great. I didn't mention this, but I did have, in 5 years, I recruited 200 families. I had a spreadsheet with all the families. And I also did, I did peer-to-peer support according to clinical issues. So I had the trachea families, the gastroschisis families, the neck families, the macroprimi families, the families that were only 10 days in the unit. And that is a great challenge for families, because then it grows in itself, and you get those neck families that want to partner with neck families, and you get those trachea families that want to partner and really be peer mentors to those trachea families. So yes, I would definitely do that.
Yeah, and see, and that's one of our challenges as well. As I say often, our NICU is so small, which doesn't mean that we shouldn't have a family council, but it's just, and not that those short stays aren't just as damaging and traumatic for these families, but we don't get that chance, when it's the longer term. We have more of those smaller babies now than we ever did. Well, right now we have, over the last week was the first time we've had 0 patients in our NICU, probably that I've seen in 15 years. So
I mean, yay!
that's
That
wonderful.
means we're doing our job, right?
Try to tell ourselves,
That's
But,
the goal.
Yeah. So we go from overworking to nobody gets to work. But yeah, so it's trying to map all this out and figure it, to reach to give everyone a chance, but being able to really get that. And sometimes just that 3-day stay goes so quickly. And so I do the discharge call. So I've got some ideas and action here, but I was just wanted to get your feedback on that.
Yeah.
And Susie, you can, if you have questions, feel free to email Lelis at fpqc.org, so you can ask her. We have a couple of questions in the chat box, so in effort for time, because we're getting there, I'm gonna let Lelis handle those questions.
So this is a very interesting one. Any suggestions for merging families of different languages and cultures for working well together? Well, it depends. If the language barrier is too big and the families can't communicate with each other, then you will have two different groups. It's not advisable. It's something that I've seen in a couple of states where they have El Consejo for Hispanic and Latino families. It's very interesting, but the life and the dynamic of the group is very different because they're culturally different and rich in themselves. But so if the language barrier is too big, I would say you will need two different groups. I want to share with you some of the plugins that you can put in Zoom for translation services and transcription services that might be very, very useful for you. And also remember that with the smartphone technology nowadays, all non-speaking English families have a smartphone. So you are all going to be able to reach them remotely to be participants of your meetings. And then how do you move from passive role to the next stage? As a general PFAC chair, I try every chance to get us more involved. Oh, Italia, so you are in the PFAC. So I would say it depends. I like quality improvement. I like data. I like research, but that is not every family. And I think we need to respect the amount of energy that each family can contribute to the PFAC and the amount of involvement that they want to have. So whoever is in charge of your PFAC, in this case, you, I guess, I would design a different leveling of people. Some people are very comfortable just telling their stories. Some people are comfortable doing spreadsheets, and some people are comfortable elevating their expertise and their engagement to the next level. And so there is a lot of material, and there are a lot of programs online to inform you better and for you to serve your team better, whether it is on quality improvement, on research, on reading charts and giving better input, or in leadership skills, etc. But it depends on each family's interest. Any areas for obtaining funds for compensation aside from hospital budgets? Yes. So if you go to the grants department of your hospital, Vera, you will see that there are a number of projects that are tabled, and the funding is earmarked for different causes. So you can tailor the grants that fit the PFAC the closest, I would say. It's not going to be perfect, but those funds that are earmarked for specific purpose can be tweaked a little bit for those grants to fund the families. However, when the grant dries, the family is going to be left dry as well. So as much as it is, it's a little bump for families, but it's not ideal. The ideal situation would be to have a compensation, to have those families on payroll or in a per diem nature, perhaps. That's what a big modality of most of the hospitals with family leaders. So, but good luck. Alrighty.
Anybody else with anything? Well, if not, Lelis, again, thank you. This was a fabulous presentation. We're so glad you're part of our family, and work with us and give us so much info about the families and everything they're doing. We appreciate you so much. I'm going to let you all have the rest of your day back and enjoy your Easter week, and have a good one. We'll talk to y'all later. Don't forget, coaching calls next week. Bye.
Thank you so much.